Thank you. Okay, I'm going to have to whip through this pretty quick. I do want to say first, though, that I think this event is fabulous, and that Rajam is fabulous, and that party last night was fabulous, and my little, sort of ambition in life was always to be a manual therapist, and it was always toward being a kinder and gentler manual therapist. I didn't really enjoy procedures that were, or testing, or anything provocative, or I didn't like anything that was uncomfortable. And I thought, why do we have to do that to people? That's really not very good for them. So my whole thing has developed into less is more. The lighter, the better. Do as little as possible. Do as little as you can get away with, and still kind of be able to elicit some kind of an effect from what you do. So let's just get started. So this is sort of a takeoff on what we did last spring in Vancouver, which was also a paying conference for manual therapists, but mostly massage therapists. Oops, sorry, a little too close. Okay, so the title of that one was Making Connections, and I'm just going to kind of there's some partying from last night, and my disclosures. You don't have to read that. There's nothing to brag about there. Let's go on. This is what I really want to call this presentation, okay? How to hack the operating system and persuade it to reboot itself. So we're going to cover a few little topics here, and in no particular order. But let's look at movement. The theme today has been about movement. And I also, I want to see my patients be able to move better and everything else. Pain-free movement is like oxygen. When you have it, you don't even notice it, but if you don't have it, you can't think of anything else. And this is a tweet by Cinema Air, who's a physiotherapist from someplace on the planet. Okay, and I thought I would just kind of go through what I go through with any kind of new patient that comes in to see me. Generally, they come on their own. They come referred by somebody else that's been to see me. I do accept medical referrals, but I let the patient keep their referral slip because they might need it for insurance purposes. I don't need it because I don't bill insurance. I bill the patient. So they come in and they've had their pain for a long time, and that's really all they got. They don't have anything particularly medical to deal with. So I assume that there aren't any red flags. If there are, they will show up through just treating them, as someone pointed out earlier, I think Barrett. If you just treat them and see what happens, that'll give you indications about what the red flags may be. And there have been a few that I've experienced. One woman who had a hip fracture that, when she was getting better, but she had less pain, but she still couldn't weight bear, and that seemed really weird to me. So it turned out she had a stress fracture. And I sent her off as fast as I could to go get dealt with. And another woman who had something going on inside something deep in the pelvis, and she had hip pain, and the only relief she could get was if she did a complete, long-sitting, complete forward bend. That gave her relief. That was the only thing that she felt comfortable doing. If you can imagine what kind of hip pain would ever have that as a sign, it seemed weird to me. So I sent her off to the doctor, and it turned out she had something that had to be surgically dealt with. Okay, so it isn't like it's hard to pick up red flags. So I don't normally worry about them. I like to go for the pink ones, the indications that people have, something that they can improve upon and get better with. So all I ever do is just sit and listen for a long time. And they're telling me their whole story over again. That helps their brain build a new representation of their problem in the moment, incorporating me as the listener. This helps them learn how to be a listener to their own self after that. I hope I'm modeling something whereby they can learn how to listen to themselves better. So then I say, okay, well, that's interesting. All right, so you've had this, and you've done that, and you've been to see so-and-so, and okay, and this helped a little, but that didn't, and okay. So and then I'm putting together a picture in my head, and they are of their story back to them, reflecting it back to them. And then I say, okay, well, I think I should probably explain to you what it is I do and what I'm thinking about when I'm treating, so that you understand where I'm coming from and what I'm going to be doing with you and how we can work together on this problem. They say, okay. So I say, okay, I'm going to draw pictures here. And I draw them a picture of the brain and the spinal cord and say, okay, this is the central nervous system. Everybody, we all have one of these things. The spinal cord is the oldest part of it because it evolved first. Fishes invented that a long time ago. We inherited it because it worked. If it hadn't worked, we would not have inherited it. So we've got one of those. Then when land animals came out on land, they had to deal with gravity and they had to deal with air and less buoyancy. They had to get legs out there and they had to have more hard drive to run themselves and to catch their meals and everything else. So their brains got bigger. And so the brains got larger, and eventually our human brain developed. It's sort of the biggest one of all. It's 5 times bigger than it really needs to be to run a critter our size. And it mostly uses up a whole bunch of fuel. That's what it does for a living. And, we can play with it and make operas and sing songs and whatnot with it. We enjoy our brains, but really the part that runs our lives is a little bit smaller than the size that we actually have. The peripheral nerves are extensive. We have 72 kilometers of them in our body, and all of the nervous tissue of the body, most of it comes all the way out to skin. And the skin is heavily innervated because it has to help tell the brain what's going on in the environment. The entire nervous system is only 2% of your whole body, even though it's a great big brain and there's 72 kilometers of nerves, but it runs 100% of your existence. You are part of it more than it is part of you, the way we normally think about things. In fact, it can shut you off if it has to in order to keep you alive. It puts you to sleep every night and it wakes you up in the morning. It puts you to sleep because it's got other things to do. Then it wakes you up because it's hungry. It wants you to go get it something to eat. And, and meanwhile, it keeps you going. It keeps your heart beating and your lungs breathing. And hopefully it will roll you over in the night without waking you up. And everything works out just fine. In order to do that, it needs 20% of all your available fuel at any given moment of the day or night. 20%. 2% of your body requires 20% of all your oxygen and glucose. That's a huge proportional discrepancy. Why does it need all that fuel? Because it's so extensive, it has such a huge surface area. And it signals, one continuous cell can extend from the end of your big toe all the way up to your dorsal column nuclei right back up in here, in your medulla. It's a big, long, skinny, huge surface area system, and it has to maintain all of that and its signaling capacity. It's a big job to keep an organism alive. If any nerve in your body can't get enough oxygen or glucose or drain easily, there can be problems because the nerves have sensors in them that will complain to the brain and say, I'm hungry, I can't get enough oxygen in here, I can't get enough glucose. Or, oh, there's a backup in here and I'm getting squished on the inside, compression from within the nerve because it can't drain. Anyway, these can all be problems that bother nerves and can create signaling to the brain that the brain will deal with as best it can, but if it can't deal with it anymore, it's going to knock on the door and say, excuse me, conscious part of the brain, we got a problem in sector 17 or wherever. And it will complain, and you'll notice that as, that'll be your pain experience. And you'll think, why is my arm hurting so bad, or whatever it is. I like to think of the brain as being kind of part critter brain, part human brain. Because the critter brain definitely exists and it was there first. And yeah, it's attached to the human brain. But really this part kind of can run autonomously. This is the part that keeps us alive. And we share this system with all the other critters that have spinal cords. Okay, we already talked about that. Let's go on. Okay, I'm going backwards, sorry. Boom, 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 boom. Human brain is where we are aware of a sense of self and from where we can choose to pay attention to something. I like to think the human part of the brain is that it's the meaning maker of the nervous system. After I've talked to people and showed them these little simple pictures, I show them pictures of nerves. So I say, okay, so here's a picture of a nerve. It's a big tube, runs through the body, 72 kilometers of this, or 45 miles if you live in the US. And inside the nerves are smaller tubes, and inside those smaller tubes are the neurons, which are even smaller tubes in a bundle. Nerves have their own circulation and drainage system. It's attached to them all the way along. It's called the neurovascular bundle. The fascicles, or these smaller tubes, can slide a little bit in the nerve, and that's good for them because that stimulates the circulation in the nerve. If there's something that's hung up or caught or whatever, sometimes that sliding system gets impaired, and the nerve can't physiologically, it becomes compromised, and it will complain about that. What I'm going to do is I'm going to be touching you on your skin someplace. I might be sliding your skin around a little bit. When I do that, I'm going to be moving nerves. You're going to feel me, but I'm not going to hurt you. I do not want to hurt you. In fact, I'm going to put you in charge of me. If I'm doing anything that's creating any discomfort for you in any way whatsoever, I want you to speak up and say, Diane, that's pinching, or Diane, you're pulling on the hair there, whatever. And I will stop what I'm doing. I'll move my hand. I want this to be a comfortable experience for you. If it isn't comfortable, it's not going to work. It has to be comfortable. And not only comfortable, but it should feel even a little bit good. If it feels a little bit good, that's really good, because your brain's going to take that on a lot easier and change itself, which is what we want it to do. It has to get itself straightened out a little bit. So you're going to be guiding me, and your job will be just to watch and note what's going on, and if there's anything I'm doing creating any discomfort, let me know. Okay. So here we have a picture of social grooming in animals, invertebrates. And all vertebrates do this, and they seem to be able to do it across species without any trouble. Get rid of that arrow. Okay, and so we're going to talk now about what might be successfully hacked. If we look at the critter brain as the operating system, how can we hack that in quote marks? I'm not talking about hacking. I'm only talking about metaphoric hacking, right, in the computer sense. We want to enter the system somehow and in some way that it won't mind, and then we're going to just wait for a little bit and let it adapt itself, because that's what nervous systems do. They're adaptive. They adapt to everything, including us as part of the environment of the nervous system which we are handling. Okay, so what might be successfully hacked? Okay, pain perception. Hey, pain perception will change if the moon's going over the sky, that'll change pain perception in some people. I mean, not in everybody. Again, unpredictability is the order of the day, but pain perception is changeable. So we might be able to affect that with handling, with the right kind of handling. When we're thinking about pain, we have to remember nociception does not equal pain. I like to think of nociception as threat detection and pain as actual threat perception, which is sort of a stronger thing. Because you can ignore nociception, but pain is a little harder to ignore. You have to learn to ignore it. If you are an unlucky person like myself who cannot ignore it, if I have pain, I can't think about anything else till I get rid of the pain. And I have to go find somebody to help me get rid of it, because I can't get rid of it by myself. And that's just the way some of us are. So I'm happy to be a helper to other people that are in the same shape as me. And I really like this picture, so here it is. Okay, the guy from Norway, Sigmic. Okay, here's the neuromatrix framework of pain, conceptual framework it should be, according to Barrett. So a model should be struck out and framework put there. I agree with that. That's a better word. All right, here's what generally people want when they come to see us. They want less pain, they want easier movement, they want decreased stress, because the pain is stressing them out. At least if they're like me, it's stressing them out. And I would say that would be my treatment goals as well, is to help them to reach theirs. We can do that, first of all, primarily with pain and nervous system education. So that's why I talked to them about why there's a fuel situation going on in the nervous system, and how we're going to help the nervous system get what it wants, which is more fuel and more drainage and clearer sailing. And then we can provide novel input, which may or may not be manual therapy. It might be movement therapy, it might be some other kind of therapy. Pick your therapy and go for it. And whatever it is we do, the new physical input through the somatosensory system should be congruent with whatever you've talked about with your pain education that you've done. And I think it should include discussion about peripheral nerves and brain and spinal cord. That's my preference. So, and I think people need to look at pictures. I don't know about everybody else, but I'm terribly visual. If I can't see a picture, if I can't imagine it in my head, it doesn't exist for me. I have to have a picture. So that's why I've made a lot of pictures, and why I'm going to really fast through them. They'll all be in the handout, don't worry. So another thing that might be successfully hacked would be descending modulation. We have to get that kind of started. It's a bit like siphoning. You have to kind of suck the hose a little bit first, but after that, bam, it's like water rolling down a hill. Okay, so we generally can hack and bring that up. The brain needs to relearn how to do that, because that's what it's supposed to be doing anyway, right? It's supposed to be descendingly modulating and inhibiting nociceptive ascending input all the time. That's its job. We're going to look at just a quick look at brain evolution. So when brains are being evaluated for age, or from an evolutionary standpoint, they look at the phylogenetic aspects, the cytoarchitectonic aspects, and functional aspects. And when they look at the internal regulation system, that is what I call the critter brain. All these medial aspects of the brain, so everything up the midline, including the anterior cingulate cortex and even the insular cortex, which is a lot more midline than the neocortex, which is further lateral. That's all part of the critter brain. All the critters got those, all those parts. All the other critters, except for the invertebrates, of course. I don't know what they do. But this part is inhibiting. Okay, so nociceptive inhibiting. So when you're looking at, it says down here, what about pain? It produces a stress and emotional reaction to a challenge. There's a feeling of stress and emotion. That's your awareness of your own, whoops, I don't know what happened there, sorry. Go back. Your own nervous system doing its job of protecting you. And this thing modulates nociception, okay? So all of its parts have got all these opioid receptors all over the place, and neurons that produce opioids. So really, this system is constantly down, suppressing nociceptive input all the time. That's its job. Sometimes it forgets how to do that or something, I don't know. And then we end up in a pain situation. So the human part of the brain is basically the association cortex all over the front, for sure, and the outside of the brain out here, all the bits in color that you can see there. And they're multimodal processing areas, so they can take information from anywhere in the brain and create meaning out of it, which is pretty fancy business. And it takes a fancy brain to be able to do that, and also to consider the past and the future. And those bits of brain are good at that. So I call them the human brain. And here's the dorsolateral prefrontal cortex, and this part is the most human part of the brain, in that it matures sometime in the third decade. Like, it's really not fully online till then. And it helps choose a course of action or behavior by considering all the possibilities in the future and all of the relevance of everything and la la la. And it will choose a course of action. This is the part that has to be targeted first with education. Once that part is fully engaged and chewing on something, then you can get busy with the other stuff, as long as it's congruent with what you've just told the dorsolateral prefrontal cortex. And the patient's brain will solve its own problems. It's pretty straightforward after that. Hopefully, we hope. It's never 100% for sure. But here's how all those parts of the brain interact with each other. And down here, oops, sorry, I don't know why this thing keeps jumping around, sorry. Here's the extrapersonal space of a brain, okay? So this is where we are as therapists, and this is our patient's brain over here. So we're giving them some pain education, and it's get back here. Oh, sorry. Here is the pain education. That's going in first. It's going into, some auditory cortex or some visual cortex or something, because you haven't touched anybody yet. You've just been sitting there talking. And their brain will chew on that, and that will go all the way through the whole thing, all the meaning-making aspects of the brain over here, and it will even come out as altered physiology down here. Okay, internal milieu, that's what that means, is physiology, basically. Okay, so then when we actually do manual therapy, we're accessing all the same stuff over again in this, and it will travel through the brain again and come out hopefully as altered physiology. Butler said, we do not treat anatomy, we treat physiology. And I agree with that completely, but I'm still going to be showing you a whole bunch of anatomy anyway, okay, so forgive me. We have to think about nerves, and I like to see pictures of them. Now, we have descending inhibitory pathways, so we've got nociceptive input going up there, the green stuff, all the way up to the brain, and rostral areas, which are not depicted on this diagram, will influence the amygdala and the limbic system and all those things, and it will all trickle down through all those nuclei at the back of the brain and back down to the dorsal horn, and yay, problem solved, or at least inhibited for now. Okay, and we have physical nerves. Well, definitely we can hack those a little bit, We have to know what we're doing and be careful of them and not hurt them more and everything else. But yeah, if we move somebody's skin or move somebody's leg or push into it a little bit or whatever, these nerves are going to be moved. There will be changes in the nerves physically because they are physical structures, same as the bones are, well, not the same as the bones, but they're physical. They're macroscopic. All right, so here are a bunch of different kinds of things that might give people discomfort in their bodies and even painful situations at times. And everything under the blue banner is kind of like nociceptive input from different diseases and pathologies and all of that kind of thing. Everything in the white area would be the brain's response to that, or the spinal cord's response to that, and it would be upregulation or sensitization of nociceptive input from all those possibilities. And over on the far left side, you see neuropathic pain. This is the global year against neuropathic pain, in case you didn't know that. And I think, actually, we might be able to do something about at least mechanical deformation, okay? We can't do anything. Manual therapy isn't going to help much if a nerve has been actually severed or something like that. But, if it's only mechanically deformed, well, get on their skin and see what happens with how their nervous system will interact with you, and maybe something good can come out of that. In fact, I think that's what manual therapy actually does anyway, even though people might have other ideas, and that this might be the way it actually does help people when it does help them. All right. Let's talk about tunnel syndromes for a minute. This was conclusions drawn by Lundborg back in the 80s and 70s and 80s when he did a bunch of research on rabbits and on nerves and the kinds of things nerves need in order to stay alive under anesthetic with an orthopedic blood pressure cuff around them and squeezing them while he's fixing bones. He didn't like it when his patients woke up and they couldn't move because their nerve had gone paralyzed, even though he'd done a brilliant surgical job on their bones. So he studied this and he developed conclusions. Okay, so my favorite conclusion here is that all sites where nerves pass through tight tunnels formed by stiff tissue boundaries, they can develop compression syndromes. Okay, so the other stuff is it's also important, but we're going to keep going quick through this. Think about this. The nervous system and the vascular system are conjoined. They're codependent. They have to have each other in order to exist. The nerves need to be attached to the vessels so that they can get their fuel and their drainage. And the vessels have to be attached to the nerves so that the nerves can tell them how wide to be and how narrow to be at any given moment. So they go through life together, joined at the hip kind of thing. And these three sort of passive tubings through the body can be pulled in various directions depending on what the muscular state of the body is, or what kind of tension's going on in there, what kind of movement the person's doing. And they can get pulled in different directions, so that if these regional vessels that connect the two together get strained differently, some of them might get collapsed or kinked, others might stay open or shortened and widened like a Chinese finger trap. Anyway, whatever the case, some of them will be open at some times and some of them will be closed. As long as there's variation, it won't matter. They'll recover from whatever we do to them. If we don't vary our movement very well, or if we're stuck in one position for a long period of time, they can get the mechanical deformation can be such that it's less easy for it to reverse itself. And plus, movement habits or static positioning habits and resting positions and so on can become habitual, such that you know, if you sit for 20 years with your right leg crossed over your left leg, that's going to contribute to some adaptation issues over time, and that will be a problem for the nervous system because it will constantly be pulled one way and never the other. Okay, non-specific effects can be hacked easily. We already had lots of talk about context and contextual architecture, being a contextual architect, pardon me. Having an environment that's relaxing and comfortable to be in without the neon lights overhead or the fluorescent lights overhead. I used to have a big picture on the ceiling of my treatment space that showed trees growing up into the sky, which was really relaxing. Everybody commented on how they really liked that picture of it was like lying on your back in the forest. And it led to a sense of peace and expansion and all that nice stuff. So that kind of thing. And at least not have the light on overhead, have a floor light, you know, kind of thing. I do have a skeleton still in my treatment room, but I have it in the corner. It's invisible as I can get it. And so here's my analysis of non-specific effects. So I sort of took this picture from Benedetti and then I modified it. So this is business as usual. The brain is busy making opioids, and there's non-opioid mediators, and they're all dribbling around on all the stuff, all the critter brain stuff, and there's stress regulation happening. It's homeostasis, it's nice, it's fine. Everything's perking along normally. And there's always the potential for pain, but you know, the opioid mediators and the non-opioid mediators are keeping it down, and you never notice it. But once in a while they fail, and then you get a pain out of the blue for some reason. They don't manage the task anymore, and pain emerges from the brain. And there's no pain center in the brain, it just emerges from somewhere in the brain. So I don't mean for you to think that the pain is in that location. It's not. Okay, and so when pain arises, then it starts to affect everything. It affects physiology, it affects the heart rate, and all this stuff happens. Stress regulation is kind of more difficult, and the stress of the pain will make the pain worse, and so on and so forth. There's this stuff that if a patient who has pain is exposed to nocebos in the environment or from you, if they don't like your tie or whatever, then that can create cholecystokinin in the brain, okay, and that actually will suppress the action of the opioids in the brain. As if the patient needed that on top of everything else, you know? So we have to manage our environments, our treatment environments, such that we just, like, as best we can, avoid noceboic input into our patient, verbally or kinesthetically, okay, or environmentally. So avoid nocebo, okay? Decrease the stressors around in the environment and try to make yourself non-threatening, as was pointed out earlier today. Create an environment that smells good. There's nothing worse than smelling dust, okay? Dust or any kind of bad smell. And I would say share pain education that does not focus on posture, biomechanics, or structure. Leave locus of control entirely with the patient. And you know, you might be noticing funny asymmetric things but don't talk to the patient about those. It's not important for them to have to hear you go on about that. They're only interested in getting rid of their pain usually. Okay, with any luck, you can, create an environment that will be inducive to nonspecific effects beginning to happen. Give people hope. Hope is kind of the key thing here. If you can give them a little ray of hope, that can help a lot with getting nonspecific effects going. All right, with the right sort of attention, in about an hour, you can end up with the pain reduced. Okay, so you've given them pain education, and add nociception. Now, somebody here said that all of the interoceptive fibers were nociceptive. I don't believe that. I think a whole bunch of them are actually not nociceptive. I think there's only a certain percent that are. The rest are polymodal, and they just report business as usual in the body. And some of them are actually geared toward transducing pleasurable input into the brain, whatever. So that's the kind of ones we want to help to, if we get them fluffed up, that should help to cut down on the amount of nociception that actually makes it to the brain. Add movement homework, obviously. You got to keep things sliding around and moving around, and because motion is lotion, and it'll feed the mechanical deformation, help it resolve physiologically. It takes 3 days for that to happen. Butler said that, so it must be true. And remember, we're not trying to change anatomy, we're trying to change physiology again, Butler. Okay, so how to do a hack. All right, set the context, provide the education, determine the contributing factors, find out, be a detective, as somebody said, find out what your patient does inside their body all the time. What, not at work necessarily, what do they do after they get home? Do they plunk themselves in front of the television? Have they sat in the same corner of the couch for the last 30 years with the same leg crossed, leaning on the same elbow with their head turned toward the television set, which has never moved from its corner over there? There's you have to figure out how do they exist in there. If, in fact, you notice things like somebody standing on their left leg all the time, they never ever, it's just a thing that you stand on their left leg. What happens, you can ask them, what happens if, I've noticed you stand on your left leg quite a bit, what happens if you stand on your right leg? They may never have even noticed that they're always standing on their left leg, but you're the therapist and it's your job to not to blame them for saying, but to just say, isn't that interesting? I just have noticed that you're on your left leg quite a bit. Is that a habit, or why do you do that? What's going on with that? And they think, oh, I don't know. I've never really thought about it. And ask them how it feels for them to be on their right leg, and then they'll go there, and they say, oh, that feels really weird. Oh. And then you can say, well, your homework, and you have to do a little bit, okay? Your homework will be just to practice standing on your right leg until that feels just as normal as when you stand on your left leg. Practice every hour, just for a few seconds. Anyway, eventually their brain will adapt to the new movement input, that kind of thing, just small things like that. Okay, and then should we add manual therapy or shouldn't we? Okay, so maybe we should. And if we do, you stimulate whatever you can without adding any more nociceptive input, because what's the point of that? What's good is that going to do for a pain experience? Not very much. Instead, stimulate nociception, and I credit Jason Erickson with coming up with that. Because he did coin that. Let's talk about manual therapy and where it maybe came from. It came, when you look at the animal world is busy grooming each other. That's what they do for fun and pleasure and stress reduction. And some of them get a little bit of food out of the deal, And we certainly do some grooming, and we do it for some food. I like getting paid to do grooming, and I enjoy doing grooming, but I'm not going to do it for free, sorry. And I expect if I need some, I'm going to go and pay for some, So it's an exchange. And so Mark Crislip on Science Based Medicine blog said this. He said, monkeys and other animals groom each other often with a marked reduction in stress. Touch is good. One doesn't need to wrap it up in pseudoscientific nonsense for it to be beneficial. And I agree with him completely. Here is a paper. This is the only paper I'm going to talk about I love this paper. It's by Oberg, who I suspect might be Scandinavian, judging by the slash through the O. Anyway, so it's a paper about the reality of embodied and active clinical reasoning in physical therapy. There's been some talk about clinical reasoning today, but we do all of our clinical reasoning with our cognitive parts of our brain, or do we do some of it with our non-cognitive parts of our brain? And I would vote for the possibility that when we're engaged physically with another human being in a therapy context, that there are 4 nervous systems involved. 4. There are 2 human brains and 2 critter brains involved. The critter brains aren't verbal, but they can feel, they can sense, they have opinions, they think something's good or bad, they have responses, and their responses are directly physiological. So I think that they're involved, and I would agree with this paper in that it does stress the fact that there is a phenomenological aspect to what we do that we should probably know about a little bit more and embrace, possibly, and try to bring it into our work and bring it into our profession so that we can work with it and try to figure it out instead of trying to shut it out. Okay, and so there's all these different ways of viewing the body that they talk about: body as object, body as subject, embodied cognition and action, intentionality, minimal self, narrative self, phenomenology. All of these things, they're all like a great big bunch of balls juggling around in the air that we're doing effortlessly without thinking about it, but we're unconscious about it. We're not bringing it too much into our literature yet and that kind of thing. We need to do that. We need to spiff it up and put a tie on it all. Okay, and you got to have hands that are clean, warm, kind, slow, intelligent, responsive, and effective. If you do manual therapy, I don't think you should try to do manual therapy with hands that don't have these qualities. And so let's talk about the skin for a minute. Okay, so the skin has all these different kinds of receptors in it, and it has cutaneous fields. These are the brain's feelers all the way out to the surface of the body. And we get on those things, and we're automatically on the patient's brain. And that's my story, and I'm sticking to it. We don't have to go any deeper than the skin to get anywhere with the brain. These receptors are hardwired, and they all go into neurons that all go into the spinal cord. The big fat ones for touch and pressure go boom up the back of the spinal cord, up the dorsal column pathways. There's three neurons and 2 synapses before it hits the somatosensory cortex, the primary processing area for touch. The thin ones, which many of them are yesiceptive, not nociceptive, we want to make things pleasurable for the patient. So those thin ones divide into various pathways. Some of them go up the spinal thalamic tract along with the nociceptive input, but they're not nociceptive. They go up and they go to the same areas that all the nociceptive neurons can go to. So they can go to all the pain processing areas of the brain, no problem. But they're kind and gentle ones. They like to be touched. And so the brain is getting new information, novel stimuli from the skin that is non-nociceptive, that's traveling through the same pathways. They divide up in the dorsal horn and go back straight out into the motor system to striate muscle and to smooth muscle through the sympathetic, the autonomic nervous system. So you can actually affect things somewhat locally, like reflexively through the spinal cord itself. And that's where the softening will come, like it'll just happen. You don't have to work hard at that. You can save your hands for your old age. Okay, let's look at this. Cutaneous nerves are absolutely everywhere. You can't miss them. Okay, there's not anything difficult about this. It's easy. It's so easy, it's ridiculous. And to me, it's ridiculous that cutaneous nerves are not part of the anatomical curriculum. Because really, what else are we touching, really? They're everywhere. They're directly connected to the brain. We can get on any of them. We can do treatments. We can make up stuff. We can pull skin this way and that way. We can affect them in any direction we want to, pretty much. We can, bring the arm into a certain position and then touch the skin, and we'll have be working on the entire nerve in its depth and in its superficiality in all kinds of clever ways. You can make up things. It's fine. It's fine. You don't have to follow protocol here. Just be with the patient and do whatever it is their nervous system needs you to do. You're the app for them. Okay. Any nerve, any cutaneous nerve in the skin is going to end up inputting into several segments. Okay. So it's not a segment-specific thing you're doing. It's a segment non-specific thing you're doing. I did a dissection. I want to show you my dissection that I did in 2007. Okay, so this is, I couldn't understand how the nerves actually embedded into skin, so I had to peel away the skin and look at the rami, and these were cutaneous rami that I was able to unveil, and the dissection I did was pretty clean, so they said, you should really get a photo of that, even though they had told me they had a strict no photo policy. So I was really happy to be able to get a photo so I could show it to you. Okay, so here's my cartoon of skin and the rami going up to the surface of the skin. The hypodermis is pretty thick. And so we have a happy little sensory fascicle because all the tensions are just perfect and there's no mechanical deformation going on, and the stiff tissue barrier is posing no problem for this sensory nerve. And this would be the normal situation, you know. And then something happens and there's some kind of mechanical deformation within the system. Okay, so, you know, maybe it's because the legs were crossed for 20 years the same way or something, never any movement of another kind. Abnormal strain will occur. The spinal cord is a first responder because it's the oldest and the bossiest part of the central nervous system. So it will take over first and it'll try to help by tightening up something. That's what it thinks it's supposed to do. But that isn't usually very helpful because some other nerve somewhere else is going to be mechanically deformed and there'll be this chain reaction and There'll be some sort of nociceptive input from what the spinal cord has been trying to do reflexively. You know, as Barrett pointed out, the brain's a kludge. It's not a monolithic thing. It's a thing that evolved, and so it's got lots of messy bits. Okay, anyway, and our job is to intervene and try to help it coordinate itself better. And how do we do that? Well, we can try pulling the skin sideways and see if that helps. And if we pull it the right way, well, it will help because then the input will change immediately. It'll change for something better. And if we wait there long enough with the skin pulled sideways for a little while, eventually descending modulation might happen. In fact, probably it will happen because that's what brains do. They inhibit. Brains inhibit. More rostral parts of the brain will inhibit the more caudal chunks of brain and spinal cord and so on. So if you lose the inhibition over the spinal cord, over the motor output of the spinal cord, you get spasticity. If you lose inhibition over the sensory part of the spinal cord, you'll get too much nociceptive input that might turn into a pain experience. I think it's about helping the brain figure out its hierarchy better and getting it back on track. Okay, and it will do that automatically all by itself because that's what the reboot is. All right, so here's the characteristics of correction that Barrett mentioned earlier. When these emerge, you know your hack has been successful. It's not over till it's over. The patient has to do their homework for a while, a couple days at least, and you can expect it will get itself back on track as long as they do their homework and you've been strategic with it and minimal with it so that they actually will do it. Okay, and then you can expect resolution of the pain problem. I do have a bunch of references. They'll be in the handout. If you want more references, you can look up DNM references on Google. You can email me if you want to talk to me about anything. And I want to say thank you. Thank you very much.
So, we're going to be taking some questions again for a little bit. And I already have one question. Mm-hmm. It's actually, there's kind of a two-part question. They're related.
Okay.
And this comes from one of our online participants. So Rex Fujiwara asked, first off, how do you respond to patients or clients who want more pressure? And how do you explain this kind of stuff to those who respond well to it hurts good types of manual therapy?
Okay. if somebody wants more pressure, I will try to not have to work any harder than I have to, okay? But if they want more pressure, I'll give them more pressure if that's what they want. You know, depending on the patient, depending on the context, depending on the problem, you know. I mean, the whole thing, it's all about them, right? It is all about them. But I'm certainly not going to reinforce their belief system that they think they need pressure in order to get better, or that, you know, like, I'm trying to teach people how not to need people like me. If they want a lot of pressure, they should just go lay down on that side. Their body weight is going to give them pressure.
So, one quick question I have for the audience, this is for context. How many people here are familiar with the type of hands-on work that Diane teaches?
Oh, everybody already knows
So
all this
Just
stuff.
about everybody. So you've seen it, done it, felt it? Okay, all right, just wanted to make sure.
Okay, what was the second part of the question, sir?
Well, the second part is, if somebody typically responds well to "it hurts good" approaches to manual therapy, how do you explain this kind of stuff to them?
Oh, you mean how do I convince them to try it? Well, I say, okay, well, you know, here's the kind I do, you know, and it's lighter probably than what you've been accustomed to. And so, you know, you have an option here. You either can try it my way, or you can go to the other person that you used to get your treatment from that you liked.
Okay. So do we have some questions from the audience here? Right down here on the end. So can we get a microphone over there? All right. And anybody else is thinking about asking a question, get your hands up now so you get mine.
No
I
questions.
know we've got one.
Hi, Stephanie. Thinking about yes-asception and CRPS. Have you had clients with CRPS?
I have.
And do you use manual therapy on the ipsilateral
I
side?
use- on the what?
On the same side.
On the same side?
Yeah.
Yeah, I do. Yeah, I have and I do. And that might seem daunting or, you know, like daring or something like that. I just go 10 times lighter and 10 times slower. But I want their brain to feel me there and know that it's not a threat to feel something there.
So we've got another question coming up from Simon here in a moment.
Okay.
I just want to know who else is going to have a question. Okay, so we've got number 2. Can we go before you? Okay. I don't think he's asked a question yet.
Hi, Dan.
Hi.
I just have a question kind of related to the pain question, like it hurts good question before. Kind of by definition, we talk about pain as being an unpleasant experience.
Unpleasant sensory and emotional experience of actual or potential tissue damage.
So if oftentimes when you're working with someone, you're not putting a ton of pressure on them, but you're creating that traction through the skin, and they'll give you that input that hurts, but it feels good. So innately, that's not pain. I'm guessing because the only words that they have to use for it is hurt, but they're saying it feels good,
No,
so
no.
it's not
No,
a
you have to
painful
take.
experience.
You have to be a therapist in that situation. I would say, okay, if it hurts at all, that's not good. Sorry, I'm not going to, you know, like, I would say sorry to the patient, but I'm not going to hurt you just because you think it feels good, because maybe that's just, you know, maybe that's just something that they believe and they don't, you know, like, I want to know what their critter brain's opinion is about that. Well, if I don't feel the critter brain liking it, I'm not going to do it. And critter brains don't like it, really, usually. So.
Okay, we've got a gentleman in here in a dark t-shirt, short hair.
Raise your hand. I'm sorry.
In the second row. Ed had a question for him. Yep, right there. On your right. No question now? Oh, all right.
Hi, Diane. Thank you
Hi.
for the talk.
Hi, Brian.
You speak about drainage of peripheral nerves, specifically at the cutaneous level. If there was someone presenting and was not able to handle touch, like say someone with CRPS in an extreme, would applying this technique maybe at a remote region of the body, do you think it could still have potential for a therapeutic
Yeah,
effect?
I think it would because, like, as Barrett pointed out earlier, if you move this way, you're moving your entire nervous system, not just the part. But I do want the patient's brain to come to that part of the body. I want to entice it to come in there. Say it's a wrist or whatever. I'm thinking of a wrist because I did treat a wrist CRPS post-fracture situation, not that recently, but a while back. And so, you know, she was like ignoring that side and doing all that stuff. I want her brain to know it's safe to go and hang in there and feel what's going on. But I certainly am going, I'm just touching. That's all I'm doing, touching and holding and waiting and feeling and not being provocative in any way, trying to be quite reassuring. Maybe doing tiny little bends of the skin, but just nothing provocative. Just trying to get the attention of the critter brain without freaking it out, you know?
Thank you.
So right up here in the second row.
Two questions, my two favorite questions.
Oh,
My two favorite questions. The percentage of nerves that end in the skin, of all sensory nerves,
sorry, say that again.
what percentage of
What
all
percentage?
sensory nerves end in the skin?
Well, there's sensory nerves everywhere to every part of the inside of the body and outside of the body, but when talking about cutaneous nerves, all of them are in the skin.
They all eventually
All
end
of
in the
them.
skin.
Well, some nerves that go into muscle don't have any branches that go to skin, okay? So there's certain nerves, you know, the names of nerves. Like a lot of the nerves in the brachial plexus only go into muscles that control the shoulder girdle, and they're buried deep in the body, and you can't directly get on them through skin.
Mm-hmm.
But you know what? You can move the shoulder blade, and you'll be moving all those nerves anyhow.
Uh-huh.
You'll be mobilizing them that way.
So we don't know exactly, no one's taken a good stab at the percentage of sensory nerves that actually finish in the
100% of the
subcutaneous.
cutaneous nerves with sensory fibers that are extraceptive go to the skin somewhere. 100%.
Okay. And then the percentage of sensory nerves that inform the somatosensory cortex.
All of them.
Oh, what percentage is, maybe I should ask that the other way. What percentage of the somatosensory cortex is informed by this, by
Oh,
the,
I think about
cutaneous.
3/4 of it. Okay, so there's at least 4. The sensory cortex is kind of shaped like, well, okay, there's that gyrus or whatever it's called. The dip in the brain between the motor cortex and the sensory cortex, right? Okay, so at the bottom of the sensory cortex, there's a Brodmann area. It's just this arbitrary division that it is responsive to proprioceptive input for muscular sensation. Okay, muscular sensation, but that's not cutaneous. So that part is dealt with by that area. I think it's called BA3 or something. And then there are 3 more areas climbing up the side of the sensory cortex and up into the kind of on top, on the surface. And those 3 areas deal with cutaneous input.
so about 3/4, 75%.
Yeah, directly. And then, but isn't like the stuff that's being, you know, the processing of the proprioceptive input from muscle spindles and all that stuff at the bottom isn't also feeding into the cutaneous parts? It is, according to.
So it really throws a wrench in all the previous
The-
reviews of mechanical manipulation and the results that we get from mechanical manipulation, because we're not keeping in mind that we're moving skin in space.
No, everybody ignores skin. This has been a beef of mine for a very long time. There's so much innervation there, and the somatosensory cortex is hugely reflective of skin. I mean, that's the outside of the brain.
I think we have time for just 1 or 2 more questions. Any last? All right. Oh, all right. We have a gentleman back here who has not asked a question yet this weekend. In the blue shirt.
Hi there. I was just wondering, is there a concern with your treatment if there's an attempt to avoid any pain, that we may be reinforcing the belief that pain is a dangerous thing that we need to
No.
avoid?
No, it's not. I wouldn't concur with that at all. What we're trying to do is not be a threat. And what we're trying to do is not be a threat to the critter brain. And it's not reinforcing, like, what I find absurd is the idea that we have to inflict pain in order to help pain. As manual therapists, I really don't agree with that. Never have. I can't imagine where that came from. Probably the culture. Anyway.
I guess I mean I don't know about other people. I mean I'm trying not to inflict pain, but through treatment and through movement, that may occur. I don't know if I can avoid it.
If the patient is
because, like,
creating their own pain, that's one thing. If you're inflicting it on somebody, that's another thing entirely, right?
I guess I just don't know. I'd like to know when, but I don't know exactly when it might happen.
Yeah.
I'm trying not to, but it can happen.
It's kind of like the shoreline and the sea. It kind of keeps moving, and you're not quite, like, try to keep your toes as dry as you can.
Yeah.
Just with your question, the sense I get is that you're kind of, is that it feels like you're asking, like, do we run the risk of treating the client as if they're fragile and therefore giving them the impression that they're fragile? Is that kind of in line with what
Yeah, I mean, if you're trying to keep your toes as dry as you can, that to me sounds like we're very much trying to avoid it, and that again is, it's close to being afraid of the water.
All my comments are directed specifically and are couched in manual therapy. Okay, so it's manual therapy that I want to be clear about, that is what we shouldn't be nociceptive with. Okay, other stuff, yeah, you have to do your dishes or you have to lift them up in the cupboard and that might hurt a little bit or what. Movement might hurt, and you have to, like, teach your patients not to be afraid of moving and and that's not hurt doesn't equal harm and all that stuff. But when you are another nervous system outside of that nervous system and you are reinforcing the idea that it's okay for someone outside of that nervous system to hurt it, that's not good, I don't think. Now, you want the patient to have locus of control. I want my patients to have locus of control over me. I want them to decide where that boundary is. I don't want to assume that I know where that boundary is. Am I answering your question?
Yeah, I think so. Yeah.
Okay. I'm sorry, I honestly don't really understand the question.
All right, I think that
Is
brings
that
us to
us?
the
We're
end
done?
of this particular day.
Thank you very much.
I think there were some questions that didn't get asked yet, so that I hope that they will either track you down over
Okay.
dinner
All right.
or or write them down using those handy cards in your padfolios and turn them in tomorrow so that we can ask them at the panel discussion. You'll be here for that,
I
right?
will be, yes, okay.
Okay, all right.
Thank you, Jason.
Diane Jacobs, everyone.